Women on the whole will spend 25% more time in poorer health than men. In many cases for women, they're just simply not being believed. Women's bodies just haven't really ever been very well understood or researched. Endometriosis, it can often take 8 to 10 years before people will get a diagnosis. There's 5 times the amount of research that is done looking at erectile dysfunction, which affects 19% of men, compared to research looking at premenstrual syndrome, which is a condition that affects 90% of women.
Hi, I'm Hala, your host today. We'd love your support. A quick subscribe to this channel would mean a lot to us and help us grow. We may be small now, but with your support, we can achieve something amazing together. Thank you.
Welcome to the Visionary podcast, where we discuss science, medicine, physical health, and mental well-being.
Fiona, when I was researching you online, I've come across your conversation with KMFM News about the gender health gap. Please explain to us now, what is the gender health gap and how can it affect me?
So the gender health gap is essentially a gap between disease prevalence, disease outcomes and access to healthcare between genders. So what we know in this country is that we have a significant gender health gap. We actually have the largest health gap of all the G20 countries and the largest gender health gap, and the 12th largest gender health gap in the world. So the way that would affect you is simply because you are a woman living in this country, and therefore you're going to be affected potentially adversely by the fact of your gender.
So I'm assuming that the gender health gap is not in my favor.
No, it isn't. So women fare worse in that view. Women on the whole will spend 25% more time in poorer health than men.
That's interesting. There is a number of ideas here. In your interview, you mentioned that the gender health gap existed for centuries.
It's a systemic cultural issue. It's something that's happened for hundreds and hundreds of years. It's mainly due to the fact that women's bodies just haven't really ever been very well understood or researched. And there hasn't really been the interest in learning about women's health, women's bodies, women's anatomy in the same way that they have for men. This goes right back to ancient Greek times all the way through medicine, really. And it's really that lack of understanding, lack of research, lack of understanding that is at the core of this problem.
It's funny because we're now in 2025. We should have moved past this kind of inequality by now. Do you think inherited stereotypes play a role in this? Yes.
I mean, the one difference that people acknowledged that there was really between men and women was the fact that a female or a woman has a womb, and slightly different genitalia, obviously, but the fact that a woman has a womb and a man doesn't have a womb. And a lot of female health complaints were often related to this difference and were attributed to the fact that a woman has a uterus or a womb. We know the word hyster comes from ancient Greek for womb, and a lot of terms we use, the term sort of hysteria or a hysterical woman. These terms all came from this sort of concept, this idea, and a lot of the health concerns and issues that women would have would be put under this terminology of hysteria, and that could range for a whole multitude of different diseases. And that misunderstanding was still there. I mean, even in Victorian times, they were concerned about women going onto trains because they were worried their wombs would fall out. This misunderstanding about women's health has been there for so long. It's hard to really understand how that came about, really.
You mentioned the word hysteria. I come from Egypt, and the gender health gap is definitely a thing there. When a doctor sees a woman that complains from physical issues, whether it's a tummy ache, headache, unless they see blood, they automatically ascribe it to psychological reasons, and they even have a name for it. It's not a secret code or anything. They call it hysteria. It's so ironic because in all cultures, women, I straddle two cultures here in the UK and Egypt, and women are notorious for ignoring themselves and putting themselves last. They don't go to the doctor easily or readily. They die standing, right? So it's important to break this down, please. You say it's a systematic cultural issue. So we have two different subjects here. Let's start, please, with the systematic part. I'm assuming it comes from within the medical establishment, right? That women's issues are being treated differently, let's say less seriously than men's. Is that correct?
I think it's a misunderstanding a lot of the time. I think there is well known, as you have said, women research has been done quite extensively fairly recently looking at women's experience of accessing healthcare, and 60%, over 60% of women in several different surveys have stated that they just don't feel that they're heard or listened to by a doctor. So when they are trying to express themselves, they are being dismissed, and that is a very significant problem, that they're just not feeling that they're being heard or believed. Maybe their symptoms are being downgraded or normalized to a certain extent. So, for example, if they're saying they have bad period pains or, heavy periods, they're just being told that this is just a normal thing that they should just put up with. So I think that's something that's happened for a very long time. We also know that the default model, when you're studying medicine, certainly this was my experience as well, the default model is a man. Most of the research that is done on men, and the assumption is made that the same information that's gained from that research can just be applied to women. And we know increasingly that simply isn't the case, that women will present differently with certain diseases. They may manifest in different ways with certain diseases. There are diseases that will affect women more than they will men. And then obviously there are lots of diseases that don't affect men in any way at all, but those are hugely under-researched. So this is where a lot of these issues have come from.
Yeah. When you're saying that a woman's issue might be, let's say, downplayed or normalized by her doctor, can this be just because GPs have 10 minutes to speak to us, and the same maybe happens with men?
I think it's difficult to know. I mean, I think there is an unconscious bias possibly there when you're talking about sort of a hysterical woman or a woman not really being believed. Maybe there is a sense sometimes when you're in a consultation and a patient is talking and you're rushing to sort of get to the bottom of, you don't want to hear the full story. You don't feel what they're saying is necessarily going to be that useful to the diagnosis or the assumption that you've already come to. And that can be dangerous because it means that you're not actually listening to the full story, and certainly time constraints are going to exacerbate that problem.
Yeah. So in a real life surgery or health center, would you please give us more examples of these gender inequalities? You mentioned something about periods. Of course, periods are painful, but that doesn't mean that we have to put up with pain for a few days, plus the discomforts that we have previously. Surely medicine has evolved to sort out these issues. Would you give me more examples, please?
Yeah, so obviously there's normalizing female symptoms as just being something that you should put up with, as we said. So, downplaying a lot of reproductive and sexual health issues that women have. But there are also issues with regards to, there are good studies that show that women are not offered pain relief, for example, in the same ways that men are. So there's good studies that show that post-operatively, women will often not be given the same quantities of painkillers or the appropriate painkillers that they should be getting. We know that women attend A&E complaining of pain. They're often not given analgesia in the same way that male patients may be given. So that's something that's concerning. We know that there's data to suggest that women after having heart attacks often do much worse than men. And that's to do with how it's to do with how they present. It is to do with the fact that often they will present later in life. They'll often present later, but it's also once they come into hospital, how they're managed. And we're starting to understand that the protocols that we have in hospitals for treating some certain conditions, which have been set up to treat men, are not really appropriate for women, because women will present in different ways, and therefore women are not having or not following a pathway that's ensuring that they have a better outcome, and that's why they're faring worse. So we're starting to realise that there are more and more diseases where this may well be the case, and more research needs to be done to look into them.
Okay. You mentioned extremely simple examples of following operations, women are being given painkillers, less painkillers than men.
Yes.
Surely this is not conscious out of a doctor's head that we have to do, but there should be guidelines according to each operation. Is that correct?
Yeah,
just follow the guidelines.
Yeah, I mean, it's difficult because every patient is different. So a patient's perception of pain can be very different from one person to another. But the important thing is that people are listening. And if they're saying, I'm in pain and I require pain relief, they need to be listened to and they need to be believed. And what they're finding is that in many cases for women, they're just simply not being believed and they're not being given that treatment, and that is much less likely to happen to a man.
I'm trying to be the devil's advocate here. Maybe there are some side effects to painkillers or something, but you're telling me that this is systematic.
I don't think it's an intentional thing. I don't think it's in any way ever an intentional thing that a nurse or a doctor is not believing that person because they're a woman. I think there's just an unconscious bias there that maybe people have that view, they're just being a bit hysterical, or, they're making a bit of a fuss.
Women complain a lot.
Yes. Oh, here we go. Yes, exactly. Being a bit dramatic. Those sorts of terminology are quite often used for women, but they're not really, you wouldn't often say, this man is being a bit melodramatic, but you often would hear that said about a female, perhaps, So
maybe because we women are usually more vocal and expressive of how we feel.
And I think there are also women, there are many, many women who are, and men, but there are many women who are very strong. Women have been through childbirth, they've experienced high levels of pain. Maybe there are some women in context who just won't feel that they want to make a fuss. They will just sort of put up with it and get on with it quietly, even though they might be struggling more than others. So, maybe that also sways, maybe they don't ask for pain relief in the same ways as well, which may mean they're not given it. It's hard to know.
So if I'm looking at a small survey or a statistic, let's say 10 women present with a certain kind of symptoms, chest pain, for example, in any surgery, male or female doctors, it doesn't really matter. Would women receive less investigation into the causes of that chest pain?
It's possible, yes.
Compared to 10 men?
Yes, it's possible. I think from the moment they walk in the door, there may well be an unconscious bias. So if your typical male patient that you would present potentially with something like a heart attack, you would be looking at a slightly overweight older man. So if you get a demographic of any person who doesn't fit that sort of criteria, you may start to think of other possible differential diagnosis instead of thinking of the more critical ones. So right from the outset, are you picking up in some women, that they might be having angina, or, is their chest pain being taken seriously? Could this be a heart condition? Could this be a very serious condition? You tend to always want to, when you're seeing a patient, rule out the worst case scenario first, and then you can work your way back from there. Excuse me. And so often women will be given alternative treatments, alternative diagnosis will be sought, rather than thinking that that's what needs to happen, that they need to maybe go into hospital. Then once they're in hospital, the investigations that are done for patients, the results from those investigations will be slightly different for men or for women. So they are interpreted, again, using the male as the default setting, and they may not apply directly to women. So we look at a particular chemical called troponin. The levels are slightly different in men and women presenting with MI. You might then decide that you want to look more and do more investigation. Men will have a bigger cardiovascular disease burden, so they'll have more blockage within their coronary arteries. But women will have greater plaque instability, for example, in their blood vessels. And because they may not present in the same way as the man, or their data might look the same as a man, they then don't go on to have the necessary investigations that they may then need. And that can then lead to detrimental outcomes. So this is where it's not that they're necessarily receiving less care, it's just that they're not receiving the appropriate care. And again, I don't think this is in any way intentional. It's just that because we don't have the data and the research about how these diseases present differently in women, we're therefore not treating them as effectively as we are treating men for the same condition.
Yeah. So this sort of underdiagnosis comes primarily from under-research on how I might get a heart disease compared to a man. So it's not just about my biological function of being a woman with a womb and ovaries and carrying babies and all these things, and a man having a penis, all these differences, understandable. But there are differences in how our I contract diseases.
Yes.
Okay.
Yes.
And this affects me differently than a man's, hence the treatment should be different.
Yes, that's right. Yeah.
So you're telling us that women feel that their concerns are being automatically dismissed. Let's talk about the most common health issues where women face worse outcomes than men.
Yes, so about 12% of GP appointments are for women are to do with their sexual and reproductive health needs, and so the vast majority is actually not often related to those things. The diseases that mainly affect women, the diseases that affect women more than men tend to be autoimmune conditions. So things like lupus, polymyalgia rheumatica, those sorts of conditions. Mental health, we're noticing there's a significant increase in female mental health problems. So we know that's dementia, osteoporosis. These are all very common conditions where women are significantly affected more than men.
Does this mean that more funds are being channeled into male dominant or gender neutral conditions?
Yes, so we know, there's good US data that shows that there's twice as much research that goes into health issues that disproportionately affect men than women.
Pertinent to men.
Yes, we know that, there's a very good example. We know that there's 5 times the amount of research that is done looking at erectile dysfunction, which affects 19% of men, compared to research looking at premenstrual syndrome, which is a condition that affects 90% of women. And I think in terms of public funding, public funded research, less than 3% of public funded research is invested in female gynecological and sexual health. Yeah. But 1 in 3 women will be affected by at some point in her life by some gynecological or sexual health issue.
You would think that there would be adequate research into women's issues with the menopause discussion taking traction and almost exploding in the media and podcasts in the last 5 years. But now you're telling us that there is some sort of discrimination in access, diagnosis, treatments, and also how we conduct research when it comes to women's issues. And as a result, women feel that their health is not being acknowledged or recognized. Fiona, you've been a GP for the last 20 years. When you come across these statistics, how did you feel as a GP and as a woman?
I think when I first was made aware of this, I was really very surprised. It wasn't something that I had really had much awareness of, to be honest. So I was surprised initially. And then I think it really made me reflect very much on my own experience, on my own practice. Do I hold some of these prejudices, bias? Am I slightly biased when I'm talking to female patients? So it did really make me question my practice. And I think it just also motivated me really to look at ways in which as a mother of girls, as a daughter, having lots of female friends, seeing lots of women in my practice, it motivated me to think, well, what can I do that's going to change this?
We women have periods, we carry babies, we breastfeed 2 decades, and we go through menopause. It's a long journey of hormones fluctuating into us. I'm now thinking of how hormones affect our mental health. I'm a different person the week before my period. Completely different person. I have every month I have a calendar entry. My period is here. But that's very insignificant, because the most important thing is another entry a week before telling me my period will come in a week. So if I'm moody, temperamental, anxious, I know why. I watch out for the signs. I'm now thinking, do you think this is part of the problem, that by default we place more demand on the system, the healthcare system, than men?
We do place more demand on the healthcare system, but that isn't entirely because of our hormones and because of our reproductive and sexual health. That actually only makes up quite a small proportion of our sort of NHS or medical burden. Really, a lot more of the healthcare that we seek is mainly down to diseases and disorders that affect women disproportionately more than men, or diseases that are present differently for women or for men. And then there's obviously a portion. So it's about over 50% is that category. And then there's about 45% that is then diseases that affect men and women equally. But I think it's important to note that the sort of statistics that I've seen that show about 5% of the disease burden for women comes from reproductive and sexual health. Obviously, that can be different for different women. But that is going to mainly affect women at that very critical stage in their life. So it's between the ages of 15 and 50, or maybe 60 actually, when most women are trying to become educated, are working in jobs, are trying to build careers, are often carers for their children or other family members. So it's a time in their lives when even small factors that, they may not be very significant health issues, but these things significantly impact women in that time.
So we have discussed the institutional part of the problem. Then there is the cultural part. Does this come from women themselves?
So there was some good research that was done recently by Benenden Health, and they were looking at the gender health gap and how women understood this. And they asked women how they felt about seeking advice from doctors. And we do know that about 35% of women who were spoken to said that they just didn't feel comfortable going to talk to a doctor about their health problems. So I think that may be because they've had a difficult experience in the past. Maybe it is because they haven't felt listened to, and therefore they felt it's not really worth going to see anyone because they've never had a very satisfactory outcome. But also it may be that they feel embarrassed to talk about certain things, that they feel shy to talk about things as well. So I think that can be yes, exactly. Yeah. And also women are very busy. Women will often they'll often be working, and then they're often, have care roles out of their work hours as well. And so simply fitting in appointments and we know obviously at the moment it's difficult in the NHS, particularly in primary care, to get appointments, to have those at a set time. It's not always convenient to make those appointments. So it's really difficult. We also have a bit of an issue regarding screening as well. Women are often reluctant to attend for screening. And again, that's for many different reasons. But sometimes it's simply just that people just are so busy. It's just hard to try and find a time to fit it in. The number of times I say to patients, you're behind on your screening, please can you make an appointment? And they say, oh gosh, yes, I know I am. I'm sorry, it's just finding the time to fit it in.
35% is definitely a big percentage, but I totally get it that we sometimes are reluctant to talk about sexual issues, intimate subjects in a medical environment, especially if I can't find a female GP available for weeks.
I think it's just trying to empower women to say try not to be embarrassed to talk about these things. It's absolutely fine and reasonable to talk about them. I think sometimes people say, the number of times patients will start a consultation with me by saying, I don't want to waste your time, but I just want to ask you about this. Or they'll start by saying, I'm sorry, Dr. Warner, this is a bit embarrassing, but I hope you don't mind me bringing it up. And,
self-conscious.
Exactly. And I, will always say, you please don't in any way feel embarrassed. There's never anything, it's very unusual someone will ever tell me anything that I haven't heard before or seen before. But it's just empowering women to feel more comfortable. I think we are talking much more. I think there's been some really good work that's been done by a lot of, we know about this sort of celebrities like Davina McCall and people that we see on television who are doing an amazing job at starting the conversations. And so many women have come into me because they've seen these programs and feel more comfortable to be able to talk about it. I think people are talking to their friends more about things as well. But it's difficult. If somebody is shy and embarrassed, sometimes it's difficult to say to them, you can't be shy and embarrassed. That's just something, it's part of how they are. Different people are very private. Different people find things difficult to talk about, but never feel ashamed or that you're wasting a doctor's time to discuss these issues. They are very, very important, and you have every right to raise them and discuss them as you would any other health complaint.
Yeah. And we do have the bad habit of putting things up checkups. I have 2 blood conditions. And a list of other diseases, but I have 2 blood tests and blood pressure and 1 scan that I do need to do for various reasons, and I've been postponing them for a long time now. But I know this doesn't sound good, but I can't fit them in.
Yes.
It's not only about the tests. There are tests in my surgery. There are tests that I have to go to a hospital for, and it's also the follow-up appointments. I just can't fit everything in.
Yes.
This is not right.
Yes.
But it's we often juggle multiple responsibilities, and we have the household, we have the kids, we have a partner to look after, we have a full-time job.
Yep.
It's not easy to optimally look after ourselves. This situation seems like a double-edged sword. The NHS has its own shortcomings, but even when the service is there and willing doctors like yourself who are happy to receive the complaints and fix things, we don't take full advantage of the system. If there is one essential checkup that you would recommend for every woman, what would it be and why?
All women are entitled to have a full NHS health check every 5 years over the age of 40. And I think that is certainly just something that is worth doing. So even if you have no health complaint that you feel is something that you've ever felt you've needed to go and talk to a doctor, it is sensible just to go for a routine checkup, just to have your blood pressure checked, have some routine bloods done, and have a bit of a conversation with the doctor. Often there will be a few, maybe small, you may think, niggly symptoms that you haven't felt you've wanted to talk to a doctor about, but actually might be something that's quite important to discuss. So I think that would be a good start, certainly, and making sure that you're attending for screening that you're invited for. So cervical screening, breast screening, and your bowel cancer screening, because those are all very useful things.
And do I receive a letter for all these checkups, or do I have to initiate?
For screening, you should be receiving a letter. For the health check, I think you have to be more proactive. You may receive a letter from your GP practice, but you may not. And if you're not aware of that, it is something that you are absolutely entitled to do. So just book in an appointment with your GP and just say, I haven't had a health check for 5 years. I just want to have a checkup. Is that okay? And yes, it is okay to do that.
Of course.
Yeah.
So in your conversation with KMFM News, you mentioned that the health gap might be an English thing. I loved that expression because I'm totally convinced that we are such a peculiar nation. Do you think we are more conservative when it comes to talking about ailments and diseases?
I think we can be. I don't want to just say English. It probably should be British thing rather than English thing. But yeah, I think we can be. I think we can be sometimes perhaps a little bit prudish, perhaps, or
we are.
A little bit uncomfortable to talk about these things. I mean, certainly if I think of my parents, my grandparents' generation, and I think it would be fair to say they are just not in any way comfortable to talk about, reproductive and sexual health. Really, these are things that you just quietly get on with and you don't make a fuss. So I think anything that's embarrassing, difficult for some British people would find that slightly more challenging. But I don't know. I mean, I said that in the interview. I'm not sure exactly how that does compare to other cultures, and actually there is evidence to say that in other countries you will have a percentage of people who will still continue to feel embarrassed to talk about those things. I don't think it's an uncommon thing, but I think we are in this country, sometimes we are a bit embarrassed and we don't want to make a fuss about anything either. Yeah, we don't
like drama.
We don't like drama and we just want to, quietly sort of, let's just deal with this. And, I'm sure it's nothing. Again, patients will come in and say, I've got this, I'm sure it's nothing. I don't want to waste your time. And I'm sure it's not something that, we need to do anything, but I just wanted to check with you. They don't want to be a bother. They don't want to cause any problems. So there is that.
There is a motto of march on, keep going.
Yes.
Don't look behind.
Yes, absolutely. Yeah.
Now, we have the systematic element and we have the cultural element. I have a tiny example here. While I was researching this episode, I've come across the fact that PCOS, which is polycystic ovarian HRV syndrome and endometriosis are often underdiagnosed, yet they affect so many women. I myself had PCOS in my teenage years back in Egypt, and I was given lots of hormones to treat it, and I think that messed up my whole body even more. Now, these two conditions being underdiagnosed, is it because doctors detect them late, or is it because us women seek help at a very later stage? Is it systematic or cultural?
It's a bit of both. So I think, again, getting back to that whole concept of normalizing symptoms. So for both for doctors and for patients, what is normal? What are normal periods? There isn't very much education given to young women, girls in school about what is actually a normal period. We learn about periods, we understand why they happen, but we don't get told this is what's normal and this is what's not normal. Most women don't really understand the differences between pain experience for some patients, how much blood you lose, all of those things. So there are a lot of people who will just not present with symptoms because they just think it's something that's normal, and they have to just accept that that's just, something they have to put up with. So there are those people who present quite late because they are experiencing those symptoms and just don't feel they need to see anyone, or don't feel it's going to help to see anybody. And then there are also those patients who do come, and they come many times, and we know with endometriosis it can often take 8 to 10 years before people will get a diagnosis from first presentation. Their symptoms may not be felt to be anything that requires any further investigation, so they may be treated again perhaps slightly inappropriately. They may be given hormonal treatments, being put on the pill. They might be given analgesia, but no one's actually starting to think about other possible options and then how that can be investigated. And again, with diseases like endometriosis, for example, it can be quite a difficult one to diagnose, because at the moment, the sort of gold standard way of diagnosing it is by performing an operation and doing laparoscopy, which is obviously very invasive. And there are long waiting lists for gynecology. So even if you have an assumption that might be what's happening, it can take a really long time before from the doctor referring a patient to then getting the answers. And yes, with PCOS, with polycystic ovaries, patients will have irregular periods, and they will often just be put onto a pill to try and regulate their cycle. But that often for some people might not be what they want. They just want to understand what the implications of that are, and what that really means for them and how it affects them. And it can affect women quite differently. And it's just, again, it's important that you listen to the patient and you take the history and you understand for that particular person how it's impacting them.
Yeah, for the cultural elements, we're also so used to looking after others, and we put our needs last. In my household, I'm never a priority. Any chores come first. Anything and everything come first.
Yes.
And we tend to do everything ourselves too, even if there was a partner, but we're so bad at delegation.
Yes.
Yeah, but and there's usually no one to complain to. So there isn't that emotional relief going on. So I think apparently this mindset also extends to the ability or the willingness to seek help. Mm-hmm. That we're super independent. We function as super women. We do
absolutely.
So, and we think, okay, I'm having under control.
Yes.
I'm going to manage.
Yes.
And we just march on.
Yes. Yeah, we do. And I think often we don't realise how much we are impacted by our symptoms. And I sometimes will say to patients, I'll have patients who will come in who have either terrible pain or very significant mood disturbance or menstrual migraine, for example. And they'll say, well, it's only 2 or 3 days each month, I can manage that. But actually, when you add that up, that's so many days in your year that you're actually not feeling well, or that it's impacting on your work. And sometimes I'll say to women, just put a cross in your diary or on your phone on the dates where you've had symptoms, and then actually just look at it and decide, how you'll then be able to see what a significant impact it's having. And that might then demonstrate to you that maybe you do need to seek further action on this.
When you called it a systematic issue, it is a system.
Yes.
Because I totally sympathize with GPs. I had amazing GPs in my lifetime here in this country. I moved here 15 years ago, and I was beautifully looked after here in Tunbridge Wells and back in Leeds, West Yorkshire. I had my child in St. James Hospital. It was an amazing experience. So I was very, very lucky. But again, we have 10 minutes, and usually it starts by me a very quick delivery, because I'm conscious of time, quick delivery of my symptoms, followed by diagnosis according to guidelines kind of thing. But there isn't time to discuss my lifestyle, my diet, my habits, and build rapport and trust with me so I can say more.
It is, yeah. And I think that's the thing that I find most difficult within the NHS system is the time factor. It is really difficult to, and we're fortunate in general practice that you do have the opportunity to build a relationship with a patient over a period of time, because you can see them and follow them up, and you can develop a relationship that way. But obviously that's not always possible in a more acute setting. So yes, it is very difficult. And I think it's, it's the same if someone presents into A&E, you're just trying to get to the bottom of exactly what I need to do with this particular patient on this particular moment. And you're not always being able to take a full holistic view.
Having said that, what do I do if I see a doctor, male or female, again, it doesn't matter, who downplays my concerns without it turning the whole situation into some political advocacy kind of thing? I just want treatment.
I do. I think it is difficult to know how to manage that. If you're in an environment where, or if you're in a practice or a situation where you're able to seek advice from an alternative practitioner, then that's certainly something that you should feel confident to be able to do. I think it's also fine to feel empowered to question the treatment or the advice you've been given, and maybe once you've had time to reflect on your experience, book another appointment. If you can't see a different doctor, go back to that doctor and say, I just was a little bit disappointed by what was suggested, or I didn't feel perhaps that I explained myself well, or that you didn't perhaps understand quite exactly what I was trying to convey. I think it's just important that you have every right to be heard, to be listened to. And if you're not, then please make sure that you feel empowered to be able to express that.
Mm-hmm. So when we talk about research, who does the research? Is it, if we talk percentage, medical research, the NHS, private sector, for example, or big pharma companies, who's responsible here? How can we address this? Who to speak to?
There's government funding for research, but there is also a lot of private research that's done by pharmaceutical companies or independent in all sorts of different genres. So I suppose a lot of the bottom line is to do with profit and how people are going to make money and how, what gains are going to be coming from that research. You'd like to think it was all just simply done because we want to know and it's good for society. But I think a lot of it can be driven for other reasons. So I think it's just making sure that people are aware that this is a space that people are gaining interest in, and so trying to incentivize people to research in these areas.
And maybe because there is the opinion that if we target gender neutral conditions, this will benefit more people.
Yep.
Okay. So based on the last 5 years of your medical practice, is this gap shrinking or increasing?
The data suggests that it's actually increasing rather than shrinking.
So how do you see things changing in the future? Will it get worse?
I hope not. I don't know, but I hope not. And I think there are, we now have the Women's Health Initiative in the UK that was published in 2022. So there is now a real push to try and bring this up as a more significant agenda, which is really great. And there's some brilliant people who are working very hard. Dame Leslie Regan has been appointed Female Health Ambassador. And they are trying to push for more research, more services available for women. They're trying to put more money into services for women, for greater access, creating female health hubs. So there is a movement to try and move this forward, but it is going to take time. Research is not something you can just do in a short period of time. Often you're having to study disease patterns over a prolonged period of time. But certainly there is definitely a greater sense that something needs to be done, and action is now being taken, which is encouraging.
So despite best efforts, the gender health gap is increasing. Why do you think that?
It's just hard to know. I think it's just because we have systems in place that have been in place for a very, very long time. And it's very, very difficult to change the way things have been set up. It's very difficult to change attitudes. It's very difficult to change systems within hospitals without recognising how significantly this is impacting. There can sometimes be a reluctance to make these changes. People don't want to put the work in to necessarily change things that significantly. And it's so many things need to be addressed here.
Yeah. We don't usually think about social contacts, like hopefully good relationship with a family, a number of close friends, bigger circle of acquaintances, to be in a good relationship with the community, church community, school community, people you work with. It does tie with the stress elements, because if you're feeling isolated, that's not a good thing. If you have extremely troubled relationship with others, it doesn't help as well.
No, that's right. It's very, very, very important. And there are lots of studies that show how important that is. It's probably even more important as you get older. I think when you're younger and perhaps you're working and you're interacting with a lot of people, it might not be so relevant. But as you get older, it's really, really important that you maintain those social networks. A lot of older people, just because it may be more difficult for them to socialise, can go very long periods of time without seeing people, and social isolation is a very poor predictor. It's a predictor of very poor health, if you're socially isolated.
Totally relate to the point you just mentioned about age. In my younger days, I'm 46 now, but in my younger days, I'm a city girl. I still define myself as a city girl wholeheartedly. I was born in a city, grew up raised in a city, and I loved it. But when I had my child, I felt that the city is so big, and I need a well-knit community. So when we moved to Kent, I chose to live in a town.
Yes.
Yeah, I was a bit apprehensive of how things would go. Maybe the community will suffocate me, but no, it's just fine.
Yes.
Yeah, I found it intimate and cozy.
Yes.